Can
everyone see those slides?
Yeah.
Yep, showing up good.
Perfect. Yay, hi everyone. This is Lola Nedich. I'm the coordinator of the Harvard and Beth Israel Deaconess Medical Center site for the New England Mental Health Technology Transfer Center. Please feel free to introduce yourself in the chat box if you'd like. And now I just want to review a few housekeeping items before we begin. Participant microphones will be muted upon entry. If you have questions during the event, please use the chat box. You can message me or Kelsey privately if you have any technical difficulties. This session is being recorded and it will be emailed out to all participants once available and posted to the MHTTC and MapNet websites. If you have questions after this session, please email newengland@mhttcnetwork.org. At the end of this month, we will send you a certificate of completion that you can then submit to your particular board for continuing education credit. Please contact Fisher at c4innovates.com for more information on CEs after the event. These are some MHTTC acknowledgements. The MHTTC network uses affirming, respectful, and recovery-oriented language in all activities. That language is strengths-based and hopeful, inclusive and accepting of diverse cultures, genders, perspectives, and experiences, healing-centered and trauma-responsive, inviting to individuals participating in their own journeys, person-first and free of labels, non-judgmental and avoiding assumptions, respectful, clear, and understandable, and lastly, consistent with our actions, policies, and products. And with that, I will hand it over to Dr. Keshavan for some.
Thank you, Lola, and good morning and good afternoon, everyone. It's my incredible pleasure to introduce my friend, Dr. Robert Laitman. Dr. Laitman is a internist and nephrologist who is from whom I have learned a lot more psychiatry from any psychiatrist. He, over the years, has become a go-to expert in the area of clozapine treatment. He's sought after nationally, internationally for his expertise. Dr. Laitman got interested in this work after his son Daniel was diagnosed with schizophrenia and was treated with clozapine successfully, and has been doing this since 2006, and has really perfected this art of using this really incredibly complicated medication, but at the same time, incredibly powerful medication in the treatment of people with serious mental illness. He and Anne Mandel, his wife, who is also an internist, have written a book together on clozapine treatment. And I'm privileged to have collaborated with Rob on a recent paper, which we'll be happy to send around, on a model of using clozapine in clinical practice, which is called the EASE model, which he will tell you a little bit more about. Dr. Laitman has his practice in Westchester, New York, and he wears other hats as well. He's also on the board of directors, along with me, on what is called the SPA, that is Schizophrenia and Psychosis Association of America. And so he does tremendous community service as well as education, and many of his ideas are testable empirically through research. So please tune in very carefully to all that he's going to say, and we'll learn a lot from that. So without further ado, Robert, it's all yours.
Thank you so much, Kesh, for that really nice introduction. Let me share my slide. Good, and go to slide set. Let's go slideshow. There we go. Perfect. So as Kesh said, and very kindly, yes, the acceptance that I've gotten from the mainstream of psychiatry has been really quite instrumental, from people as esteemed as Keshavan to, my earlier days with Lou Operler, who I co-wrote the book with, to Fuller Torrey. I've been really, very pleased with the acceptance. And I think the time is right that people start to understand that maybe we can't cure schizophrenia, an argument that Kesh and I still have, though we can get pretty damn close because we can get people incredibly better. So this talk again is about what I consider the optimal treatment of psychotic disorders. And if you're really going to talk optimal as opposed to good enough, it means clozapine, engagement, and community. Whoops. Ah, there we go. So there we go. So that's Daniel. Everyone has a son or a daughter before they, unfortunately, in our society, often become homeless, incarcerated. That seems to be the more often outcome with people with psychotic disorders. But we're here, and you guys are here, and obviously you're here because you're doing part of a first episode psychosis program. You believe that it can be very different, and for our son, it was, and that's why we're here. So I want to talk about what these psychotic disorders are. They're complex, and I'm going to be brief because I think you guys know it. Heterogeneous, polygenetic, and really neurodevelopmental disorders, and they start before birth. So in terms of, and I wanted to put a little aside for cure, we need to be aware that there are some things that we can do in the families. For instance, we know that a lot of these genes are, for instance, dealing with the nicotinic receptors. We know that if you improve cotinine, in other words, you give a supplement, something called phosphatidylcholine, you can impact these kids' neurodevelopment. And there's ongoing studies led by Dr. Friedman that we can change the trajectory of a lot of these people's lives. Vitamin D, there's some evidence for, and a little bit for CoQ10. If you look at the very highest skyscraper there, there's a Manhattan plot. That is one gene that's very important, and that's the C4A gene that is overexpressed and leads to excessive pruning. In theory, and again, this is animal studies, if you look at all these genetic abnormalities, there's only one drug that significantly can impact the trajectory of that illness, and that's clozapine. It has direct effect on microglia. It has the strongest effect on nicotinic receptors. So I just want to put that there. Now, psychosis, we always talk about, the psychotic break, and it always drives me a little crazy, and everyone's always after me to try to get rid of every positive symptom. And I just think that's the wrong approach. My goal, on the other hand, has always been to get to the point where they have at least the ability to think about their own thoughts, something called metacognition. And once they get to that point, then I can go on and try to address other things in terms of their psychotic disorders, which are the more important and debilitating aspects, which are the negative symptoms and the cognitive symptoms. Again, there is only very small evidence that any other of the antipsychotics impact all these other modes in psychosis. And, for that reason, we go to the reward network, mood symptoms, for instance, the ultimate expression of that is suicidality. Well, clozapine has the FDA indication, as you know, for suicidal risk, and will decrease that by 90% compared to all other antipsychotics, and about 30 or so percent compared to olanzapine. But again, getting back to what debilitates people, it's the negative and the cognitive symptoms. And clozapine, there is starting to be some mounting evidence that it impacts that. Finally, I do add comorbid substance abuse because that is such a common denominator. If you're going to include alcohol and cigarettes, well over 80% of these kids are users. Only one antipsychotic significantly impacts that, and that is clozapine. Oops. Uh-oh. And I am stuck. Hold it. Ah, there we go. Thank God. Whew. Okay. So again, I want to reemphasize this slide. and talk a little about it because the neurobiology, it's the risk factors. But you guys are a first episode psychosis clinic. But where you're getting these kids is years down the road. The negative symptoms will often develop first, and the illness is going. And really, untreated psychosis has been present for some time. We know untreated psychosis worsens outcome. So the clock is ticking. And, you know, I can't argue with the approach of starting another antipsychotic besides clozapine in the very beginning. I mean, on a personal level, I would not do that. I strongly believe that clozapine from the onset should be the drug of choice, but my evidence isn't great there. That's just my personal experience. But there's no question in my mind, if these kids are not having a full and meaningful recovery, you should be going over to clozapine as early as possible. And I think you're losing time. And as negative symptoms go on, a lot of these kids will present to you and they'll change diagnosis on you. Often it'll be with substance abuse. It'll be called psychosis with, cannabis abuse. Then all of a sudden, they give up the cannabis and you're still having episodes and they're quote unquote manic, having, grandiosity, but part of the psychosis. You're calling it bipolar with psychosis. In the meantime, you're keeping them on these D2 blockers and really not impacting the trajectory of the illness. The negative symptoms gallop along and there's more and more of a thought disorder. And you go down the spectrum from schizoaffective to schizophrenia. And my goal is not to do that. So clozapine, why don't we use it? It's got a bad rap from the very beginning. People didn't understand it. Is really the second major drug that came out after Thorazine in 1958. So it's been around for 65 years, but it wasn't what we call a neuroleptic. The whole D2 hypothesis, when I grew up and I was early in medical school, we were taught that we had to basically make our kids Parkinsonian to really get to the point where there's enough D2 inhibition to impact their psychosis. And yes, all these drugs work because they do work on dopamine dysregulation. Yes, they do show improvements, but nothing like clozapine. So nevertheless, patients got it. They loved it. It was out there as a Q8-hour drug, and then it hit a huge snag. In 1975, 16 elderly, and I want you to remember that, Finnish women in a small Finnish village developed severe neutropenia, and 8 of those succumbed. As it turns out, reviewing their course and looking at the original paper, and this is forgotten, they were all on other medicines that could have caused agranulocytosis. Nevertheless, that led to clozapine being withdrawn from the market and only being reintroduced slowly into Europe and the United States. John Kane with Gil Honigfeld from Sandoz and FDA came up with this rather complex model to approve clozapine in the US. And they put tremendous hurdles, as opposed to using a new drug development where you just say, is it better than a placebo? They posited that it had to be, and this is where we start to talk about resistant schizophrenia and resistant psychosis. It had to be better than having failed 2 other antipsychotics after given a documented, compliance with those drugs up to 600 milligrams of Thorazine, and then having failed again 60 milligrams of Haldol for an additional 12 weeks. And the study was comparing Thorazine versus at 600 milligrams versus clozapine at 400 milligrams. It was not optimal study for clozapine, but what it showed was Thorazine, there was essentially zero. It was, I believe, 2% response rate. And with clozapine, there was close to 30% people that showed significant improvement. And that led to clozapine coming back onto the market. But once it hit the market, it had a very short half-life. It was rationed. It was put into this very strict remediation of medical side effects, the mandatory blood test. They made it very difficult to use. And essentially, even after it got the indication for suicidality, the Sandoz decided not to support it and went to easier drugs to use, and clozapine languished. The highest penetrance in the United States was below 10%. And right now, if you're going to talk about all people, that 50% never get treatment, we're talking 2% of people with psychosis, and probably significantly less because it's hardly used at all outside of resistant schizophrenia. So this is when I went looking for it for Daniel. This is all I heard. I heard how it was horrible. I was told just absolutely ridiculous statistics that 3% of people would develop severe neutropenia and most of those would die. He was going to be a fat slug. He'd have, just gained so much weight, develop diabetes, constipation, myocarditis, thromboembolism, pulmonary infection. All these things were horrible and not remediable. That's why we call it the drug of last resort. It was absolutely far from the truth. And it just demonstrated that people didn't understand the risk and benefit, and that if you do the medicine, you get this amazing drug. And again, it's the safest and most effective. And it's better than all the other drugs in all settings that it's been looked at. It reduces violent behavior, substance abuse. And you know what? Kids love it. After a year, multiple studies have shown acceptance of over 85%. And in our hands, it's over 94%. You guys, in the first episode, Psychosis, are missing a critical period of time. That first year is such a dangerous period of time. And people die from suicide. People die from accidents. People are involved in violence. You're losing a large part of your population because you're not turning to a drug that can impact them. And, you're doing this, you got, again, 50-fold is the risk to these kids. So over their lifespan, if we were to use clozapine like it should be used, and we're worried about the agranulocytosis, I just want to give you the numbers. We would save, and I'll split the difference, about 500 lives per 10,000. And what will we lose potentially? And this is probably a high number, 1 in 10,000. Any other drug that has a 500 to 1 advantage anywhere in medicine would be being used. Also, the agranulocytosis was grossly overstated. More recent stuff, 0.3 to 0.8. Actually, I'll show you in a few slides. It's less than that. And most of the risk is in the first 18 weeks. And after 6 months, the risk is as high with the other antipsychotics. People have stopped using the monitoring system in certain countries, Iceland being one. Denmark also cuts it off early, and it's not mandatory in other countries across the world. So this is Taylor. This is a gentleman who I've just started working with. He's the head of psychopharmacology at King's College in London, and he looked at his 3,500 patients. And again, what did he find? He found in 14 years, 16 events. And what did he see? Actually, he initially had to exclude 7 of those. It was a false positive. There were only 9 events in 8 patients, and none of those people died. When did it happen? Again, everyone was in the first 15 weeks, and it was often earlier. And he titrates a little too quickly. And in our hands, and with my 15-year experience, I have never had to stop clozapine for 1 single day because of a low white count. 15 years, and we have over 300 individuals that have come and gone in our practice. And if you're going to count the people on my Zoom calls, we're close to 1,000 individuals now ongoing. It's just such an overstated problem, and we're working with the FDA. And this was Taylor's conclusions. You see a surveillance bias, if anything. You're actually getting more false positives, inappropriately stopping the medicine, causing more harm with this monitoring than you're doing. So he proposes eliminating it. I agree with him. Let's look at the FDA database, because we can look at their own data. This is the Sentinel database. This is 94 million claims, and this is the incidence of neutropenia. So if you're looking at first episode psychosis individuals, they're all 18 to 44 or younger. What's the incidence of severe neutropenia in the incidence? Well, if you look, it's 5-fold greater with olanzapine. With Keppra, which I can't pronounce that name, I won't even try. It's almost 8 to 9 times higher. You know, really, I'm waiting on the FDA. We're presenting this data. They know this data, and I'm waiting for changes. Again, the average age in Taylor's case of the A grant, again, the 51-year-old. What's the age we see people? 19 and 20. Why do you use clozapine? Well, if you're going to look at all the antipsychotics, and the FINs are the best because they have a single database, something that we lost that opportunity when we went and decided to just pay private practices and all the rest. We could have had the VA database for the entire country, and then we would have had amazing amounts of data. The Finns did it right. They have one database, so they know what happens to all their patients with schizophrenia. And people that don't take antipsychotics, at 20 years, half of them are dead. A quarter are dead with others, but only 1 in 7. It's not perfect clozapine, but it's a heck of a lot better. What drives that primarily is suicide. And, you know, again, you know, you see that with clozapine, you essentially reduce the suicide risk very close to the general population, as opposed to having that 5-fold risk. So let me tell you about the Team Daniel experience. This is a little old, this data. You know, I have to get my statistician, Rachel Strife, who's also the head of Angry Mom. She's a very busy lady. We have to look, and we'll probably do this next February because it's been really almost 2 years. So this data is a little old, and I apologize, but it hasn't really changed a tremendous amount. So we have actually well over 200 patients, and the 94% continuation rate remains. Basically, 75% of our kids are on the schizophrenia spectrum, about a quarter bipolar or other. What's interesting about our practice is we are not a first episode psychosis program. I would love to be, but most of our kids were, in fact, 54% were already on clozapine and not having an optimal response. And then the rest were there. So we're really a treatment-resistant population. And that's reflected by the age, the average age that comes in. Also, we're predominantly male. All these things would predict that we would not have a very good outcome. In fact, 60% or so, and that's about average, had anosognosia. And we've had to use a fair amount of court-mandated treatment. Not everyone's been a success. You'll never have a success. There's just too much heterogeneity. There's too much, you know, neurodiversity. We've had more and more, for instance, kids that have come to us who had started on the autism spectrum, something that I've become aware over the last few years. And there's a burgeoning literature that 20% of all the autism spectrum kids will go on to develop psychosis. But these are kids with more extensive neurodevelopmental disorders. And with that, and with learning disabilities, we don't get the same recovery. Also, anosognosia becomes and remains our biggest barrier. If we cannot get people engaged, we lose them. A few people have discontinued. You know, I've had people from 40 different states. There's different levels of engagements. We have had 2 deaths, but one of the persons was on clozapine for over 30 years, and she was 93 when she died. So that was old age, and unfortunately, I did have one suicide. And again, the loss to follow up, the attrition, it's tragic, but we do the best we can. So how are we different? We use clozapine. That's all I use. Everyone essentially is on clozapine. If they come to me on another drug, you know, at this point, I'm not taking any new patients. I'm only doing consults. But as they come into practice, we tell people we will not treat them unless they're going to go to clozapine. We feel that strongly. Also, we believe not in good enough care. We believe in optimal care. And that means a full commitment. And we believe, and we've seen, that people can get very close to where they were before they became ill. So meaningful recovery. We have community, we involve patients, we involve families. There's too much learned helplessness and hopelessness out there, and we combat that. So optimism, you need tremendous optimism. Your optimism can be infectious. People can sense that. And as the community builds and you introduce your kids to other kids that are on clozapine and they see that, it so instills in them this possibility. And we have several people, I'll mention Eric Smith and as one person who's now a peer advocate who's available to you guys to do consultative work. And these guys are instrumental. I have others also. I have one woman who is runs an ACT team who's been on Clozapine for 30 years, and they serve as our peers and our models. Again, early outcome, better survival. We know we want to stop the longer you have a duration of untreated psychosis, the worse they do. There is not a strict cutoff for Clozapine, but I will tell you, the longer they have been ill, the longer it's going to take to get better. In the one study where they've actually shown that there is improvements in negative symptoms, the average age of those individuals was 48 years old. These people have been sick for a long time, but they had to follow them out to 5 to 10 years. I tell people the negative symptoms is like watching the grass grow, but they do get better. But the suicidality, the aggression, the adherence, the satisfaction, you have to get past the first 6 months to a year. That can be rough, especially when you're just getting these people on and they have the demands that we have in the United States. But the outcomes are outstanding, and meaningful recovery is where we want to go. Unfortunately, this is what we often see, right? We wait, we wait, we wait. And as we wait, we lose gray matter. How much of this is reversible? I think a lot of it. More recent studies looking at the neuroimaging seems to show that the neurons are still preserved, but there's been a lot of dendritic spine loss, and that takes a tremendous amount of time to regrow. Is it doable? I believe so. Is there evidence for it? Yes. Is it overwhelming evidence? No. So how do we define meaningful recovery? We have a functional outcome. We want 20 hours a week or more being engaged in school, work, being a parent. We have several people that have gotten married and have kids now. I've taken 3 people through Clozapine and pregnancy. I'm going to have another one very shortly, I hope. And again, into an active rehab program, or I'll take 20 hours of consistent volunteer work, but they have a life of meaning and purpose. They're not living in someone's basement, isolated. They're in society. Whoops. Okay. So if you look at what is the best meta-analysis of recovery in the schizophrenia population, it is 14%. And of that 14%, they did not break down what the antipsychotics was. My bet is that a good percentage of those people that were considered quote unquote recovered, and it was a less strict functional recovery than I'm telling you, were already on Clozapine. So my contention is, if you have not shown functional recovery, that means that at least 90% of the people should have an opportunity to be on Clozapine. How do we do? Well, New Zealand, where they have a pretty good use of Clozapine, they did 37%. Team Daniel coming into our practice was only 26%, which is twice as good as what was already out there. But you remember, 54% were already on Clozapine. But in our hands, really doing the work, we're up to almost 3/4 of our kids in meaningful recovery. And it's across all spectrums of psychosis. We do a little better with the less pervasive illnesses, but we do just fine with what we call the resistant schizophrenia. How does AOT impact? Well, we do even better there. We've got 8 out of 9, and this has continued. Actually, it's 9 out of 9 now, all working. The last kid just got a job at Kroger's and is stacking shelves and loving it and working, 25 hours a week. And so I'm very pleased with that outcome. Everyone, and I know in Massachusetts, unfortunately, you do not have court-ordered AOT. I know it's in your Senate and your House, your representatives, the legislator. They are trying to pass it. You're one of 3 states that doesn't have it. Actually, in reality, there are 2 other states, Minnesota and Pennsylvania, that have it on the books but don't have it. So you're one of 5 states where there's really not court-mandated treatment. You need court-mandated treatment. Anosognosia can be so pervasive that you just need to have the court sometimes. And it saves lives. So what happens to these kids when they come into our practice? 93% of our kids the year to 2 years prior to coming into the practice, because it actually was 2 years, had been in the hospital. Since in our coming to our practice, we've had a 15% return to the hospital. And this is at a year and counting. This is all returns to hospital. And it also includes the adverse side effects, including a few episodes of pneumonia in the days of COVID. So if you're just going to talk for psychiatric reasons, the percent is less than 10. It's a game changer. You get off the revolving door. Weight. Everyone's worried about weight. These numbers are really old and really came before we started to use, and I'll talk more about this, the new drugs that are out there, relatively new, the GLP-1 agonists, the Ozempics, I'll talk semaglutide, tirzepatide, liraglutide, the weekly shots. But even without using these drugs, we don't have much weight gain. And if you look and you break down the population, we actually show if someone comes to us with a BMI of over 25, and that is 25 to 35, we see an average of 13 pounds. And if they're extremely overweight, and that's a BMI of over 35, we average 35 pounds of weight loss. Now, this is how the game has changed since then. This is liraglutide. And honestly, I have no connections with any pharmaceutical, but in our experience, the best drug out there by far is tirzepatide, if you can get it. I'm fond of saying it's twice as effective and half the side effects. But this is one female patient who we kind of got stuck with, initially did well, and then she crept up and plummeting down. It's not sex dependent. This is what we see. And this is, again, of the first 40 patients that went on, over 2 years, 73% were obese. And by the end of 2 years, we were down to 40%. It's really dramatic. What do we do with substance abuse? Well, again, 54% were already on clozapine. So we did a lot better. Even at the start, we only had 50%, but now we're down to 8%. And most of that was cannabis. And as we saw 82% recovery from that. How have we done with tobacco? Again, not as many as you'd expect to start with, but of those 46 smokers that we had data for, we've been able to get completely off of cigarettes in 67%. And again, we work really hard. We use all of the other medicines. Varenicline, Chantix is very useful, very well tolerated, as long as you're giving it with food and you do it correctly. But, we also just actively encourage. So is it all wine and roses? Of course not. As I said before, we've had more than our share of pneumonias, but it's interesting. In the literature, there is, and this is the biggest fear, Jose De Leon writes a lot about this from Kentucky, that 30% mortality. We've had a 0% mortality. And why is that? Well, you recognize in pneumonia, it causes an inflammatory exudate. So this is knowing how to manage clozapine. Someone calls me up and they're all in communication with me, all my patients. If they get sick, if they have a fever, we will automatically half the clozapine dose. If they're severely ill, I will reduce the dose by 2/3. Why do I do that? Because the inflammatory exudate will routinely, absolutely shut down the cytochrome P450 system, primarily 1A2, primarily 1A2, but 3A4 as well. And if you don't do that, they get intoxicated. And that is why there is such a high rate of death with pneumonia. So we've seen our share of seizures. You'll see why. I tend to push levels, the one suicide and the weight gain. Now, I want to get back to the weight gain for a second, because of those 11 kids that actually had the substantial weight gain, the greater than 7% weight gain, there was a lot of unwillingness to participate and fully take all the medicines. We're doing better with most of those kids now. What you don't see, which you'll see in the other antipsychotics, is movement disorders. And we've had very, very few people with that significant. But what you do see, and I want to dwell on this slide, and this is a preliminary data slide, and this is a global assessment of function. Basically, before these kids became ill, they were functioning pretty well. A GAF score is 80. They may have some anxiety, but they have friends who are in school or they're working. Untreated, they're uniformly in the hospital, often suicidal, certainly not functional, certainly in the throes of very significant psychosis. Do the other antipsychotics work? Of course they work. They work pretty well. Kids are twice as good. But what is a 38 on the GAF score? Well, they're out of the hospital mostly. Most are not actively suicidal, though, as you already said, quite a few still are. But they're not functioning. They're not working. They're not in school. They tend to be isolated. These are the kids living in the parents' basement. What happened when people came to us on Clozapine and not optimized, not with all the side effects taken care of, and really not pushing the levels that a lot of these people need? 56 is pretty damn good. And that was actually the same number that they used for the recovery in New Zealand. So not bad, but I'm saying you can do better if you do the medicine. We've gotten our kids close to where they were before they started, and that's the goal. So how do we do it? We get to know the family. We get to know the kid. We really let our guard down a little bit. I'm a big believer in letting a lot of barriers go. I mean, there are certain barriers you must maintain. But look, I invite these kids to my house. These kids all have my phone numbers. I try to get through. If you work around the psychosis as best you can. I use Javier Amador's approach of listening, empathizing, agreeing, and partner. See if there's something they want. But as I said, I do turn to court-mandated treatment. But I make them accept it, and I normalize. I treat them like people. They are people. They're your kids. They're your friends. They're your families. I can't tell you how much psychosis is out there. It's everywhere. It's 3% of the population. And you also have to let them know they have to be patient. This is a long haul. As I already mentioned before, the first 6 months to a year, it usually takes me that long to get to a really stable, successful regimen. And even then, the recovery is ongoing. I always say you pay it forward. You pay it forward in terms of that you have the side effects a little bit more in the beginning with clozapine, but you have an ongoing improvement over time. And you have to support these people. They all have our phone numbers, which I have on mute right now, and they all have our emails. These people need to be cajoled. I've talked a lot of people off the ledges, and that's probably why we have such a good, ongoing, treatment, that we're at 94% stay with us. Everyone leaves with my treatment note. It's all about the plan, moving forward. What can you achieve? And again, I will emphasize it again, optimism. You need optimism. So this is the optimal treatment, and I want to talk about the EASE protocol. This is Machery's acronym. He loves these acronyms, but this is a brilliant one, and I give him full credit. He came up with this. So EASE, and there is nothing easy about clozapine. I will not tell you that. It's the hardest work you're ever going to do, but it's also the most satisfying work. We're all here to make these kids better, and having done it now, closing in on 20 years, it's just remarkable. But the earlier you do it, the easier it is. Don't wait. That's the E. A is for assertive management. Therapeutic drug monitoring is incredibly useful. One, it tells you if they're taking their medicines, and two, there's a lot of heterogeneity in how these people metabolize the drugs. I'll talk to you about something that's in development now that we can look at that actually may be a useful genetic test. Ask me about that later. But nevertheless, therapeutic drug monitoring is still critical, and managing the side effects. I can't emphasize that enough. They're predictable, they will happen, and you have to ask about them and you manage them. And you can manage them successfully because you will do it slowly with the clozapine. The titration that is in the PDR is approximately 6 times too fast. And we go extremely slowly. And I will tell you this multiple times. We start out, and I do this as outpatients. And again, we've started well over 100 individuals as outpatients. We start at 12.5 milligrams every 3 days. And most of these kids have a lot of positive symptoms, and we start with divided doses because you need it. And then, more important than anything, you can't use clozapine unless you have engagement. You just can't. If you cannot assure compliance, don't use clozapine. You have to have a setting where there's, a family or a support system in place. This is why we'll start sometimes these kids with long-acting injectables, just to get them to the point where they'll sit down and be part of the process. If you have someone that's going to go on and off and doesn't have that support structure, you're going to do more harm than good. So you need the family, you need the support. But if you have that in place, there is absolutely zero reason that your kids shouldn't be on clozapine. Again, early intervention, there's multiple studies. I know this is a busy slide, but we know this. So if you fail one drug and expect to do better with another drug, 5% response rate is incredibly generous. And that is not a complete response. If you fail 2 drugs, you're talking less than 1 or 2%. So I don't like the protocol with first episode psychosis. I think you guys linger too long. I think going to a second drug is really a little ridiculous. You're taking a kid and you're just waiting and waiting. And it's just not appropriate. Again, I can't argue with the first drug because there's such a spectrum with psychosis. If someone gets better with 20 of Latuda, God bless them. I don't know if that's right or wrong because I still think these kids may have a trajectory where the illness will get worse, but that data is not in, and I don't have a big argument. So I'll go for the other 90% that I know should be on clozapine. And again, first year of psychosis, it's so dangerous. Take advantage of what you have. And the last thing, and Oliver Ho, who's the originator, well, not the original, but probably the one who really said it best, was the dopamine hypothesis. And he wrote a great seminal paper about that, explaining how that this is all about dopamine dysregulation in 1999. Did a real mea culpa in 2020. I think Masuda was the first author, where he'd always said clozapine, use it last resort. And he said, you know what? I've re-looked at the literature and it should be used in every setting and as early as possible. And it was music to my ears. Very interestingly, an article in, I believe it was just a little throwaway article, and they were quoting John Kane. Where was that, Anne? In JAMA Psychiatry, saying, we don't know how clozapine works, and we should consider clozapine, and, it's a shame that people don't use it. Well, that's lukewarm. It's Lancet, Psychiatry Lancet, all well and good. That drives me crazy too, because the data is overwhelming. We're underutilizing it tremendously. We need to use it more. And the more you use it, the more you'll want to use it, and the better you'll get at it. So assertive monitoring, as I said, we always talk about the threshold dose. That was 2 studies. There's one that said 350 nanograms per mil, another at 420. That's just about where 3/4 of the people start to respond. There is a response curve, and this is why you want to do therapeutic drug monitoring. There is continued improvement in most of these kids as they go up with their levels. Side effects do get worse, so it's always going to be a balance. And then you have to do the rational polypharmacy. You don't allow the excessive salivation. You know that the bowels are going to slow. You're going to treat the constipation. Cardiac issues are non-issues if you do it right. As levels go up, it's anticholinergic, heart rate will go up. Treat it. So, slow. Again, if you go slowly, the side effects are better. It gives you more of a chance to cross taper off whatever other antipsychotic you're on. Discontinuation rates in most studies are over 50%. And it's mostly side effects. And it's mostly because of that. They went up too quickly. Go slowly. Again, 12.5 milligrams every 3 days, unless you're in the hospital. And then you may have to use another antipsychotic to just get reasonable control. But take your time with clozapine. Clozapine is a lifelong medicine. I like to tell people it's like the insulin of the brain. If you're an insulin-dependent diabetic, you're an insulin-dependent diabetic. If you have psychosis that is like the general population, you're clozapine dependent. There's been nothing better for 65 years. We have some exciting things in the pipeline. I think they will be adjunctive to clozapine. I do not think they will replace them. And again, engagement. You need your family. I can't emphasize family education enough. And also using the courts, and I pray that Massachusetts gets this. You got to talk to your families. HIPAA does not restrict you. If you actually read the HIPAA guidelines, it says if you feel that your patient is unable to make a judgment, or in their terms, incapacitated, it is up to your best judgment what you say to your patient and their families. And certainly you can get every bit of information. Families are part of the reason why we do so well. They are on board, they support, they're our critical support structure. Without them, it doesn't work. So engagement, engagement. As I said, another mistake that we make with clozapine is I've seen more regimens where it's all at bedtime, and it shouldn't be in a lot of these kids. Now, if they're at the point where it's primarily negative symptoms, fine, dandy, and good. But most of these kids still have some prominent positive symptoms, especially early on. I split the dose. I'll even do it evenly. Certainly, as the positive symptoms get better, I will shift more and more to compliance. I'll tell you, in some kids that I have one guy working arbitrage on Wall Street, and he has to get up early, and he's working, 12, 14-hour days. He splits his clozapine 4 times because it's stressful, it manages the stress, and he takes just a little bit more at bedtime. And, what we find is the more they split, the better they tolerate it. But reality is most people can't do it more than twice a day. And again, the range, I just want to reemphasize about the range and how important it is. So again, 60% actually, all right, I said 75, hit some start of recovery. That's the start. That doesn't mean that's the optimal drug level. We will take people up, and I'll talk more about this, as high as 1,500 nanograms, and that's because we use a lot of fluvoxamine. And again, I'll talk more about that. And you're always managing risk and benefit when you do that. Again, when you start out, do the medicine, get your baseline studies. If someone's using, as Ronald Reagan said, trust but verify. I get levels at every visit. And avoid the predictable side effects. I was contemplating, because Kesh gave me an hour and a half, and I wanted to leave some time for questions. Only an hour last time. I was contemplating putting all the slides for the side effects, but I'll just do this briefly. It's just too much information at one time. But the bottom line is weight gain. The guaranteer, it doesn't have to be. We don't have an issue with weight gain if patients are willing to take these products. You start with metformin, but you go after these kids with the GLP-1s. The sodium glucose transport inhibitors are useful. It's about 200-300 calories a day if you can get them. But the bottom line are the incretin mimetics. They are a game changer for all of our patients on all these antipsychotics. And after this call, I'm calling Eli Lilly, and I want to talk to them because I want to do a study. Just, we already probably have enough information, and I'm going to publish that as well, but I want something formal with them. The triglycerides, it's the same thing. If you take care of the insulin resistance, that is typical of clozapine because it lowers GLP-1, and the insulin resistance then works on lipoprotein lipase, it decreases its activity, and then you have an increased triglyceride. The metabolic syndrome, it's the same thing. Early metformin, don't be shy about it. We'll start with the extended release. We only use the extended release. We start at 500 milligrams, and every week or two, we increase till we get to 1,000 twice a day. And we add the incremental very early because the weight gain can be monstrous with clozapine if you don't do this. I've seen kids come to me reporting weight gains of, and I wouldn't have believed it if I hadn't seen it, 5 to 10 pounds in a 2-week period. They are hyperphagic. They eat too much, and it's constant. The incremental are also good for your brain. I will refer you to my Toronto fellow, and what's his name? Roger McIntyre in Toronto does work talking about how these incremental are not only good for weight loss, they're good for your brain. Again, fast heart rate, it's anticholinergic. They're often anxious. Use propranolol, start at 10 milligrams. It does not touch your blood pressure in the vast majority of these kids. Go up slowly. If the anxiety is not bad and you just need it for heart rate control, switch over to atenolol, which does not cross the blood-brain barrier, so there'll be less sedation. I use higher levels. Again, I have a more resistant population than you guys on the whole. You're getting your kids earlier. I think you're not going to need as high levels. That's been what I found out with less pervasive illnesses, and I'll show you that with some more slides. But don't be afraid to add lamotrigine early. I use a lot of that. I don't like to use Depakote, but I will use it if they're very violent. There's a little data for that. Most of that is in the hospital. But what's not on this slide, and what I've been using a lot of, is a lacosamide as well. Drooling, very preventable. I start with the topical agents, and I will go to glycopyrrolate. Glycopyrrolate is a quaternary amine. It doesn't cross the blood-brain barrier, but it is anticholinergic, so you have to use it very cautiously, because what can it do? It can worsen constipation. You elevate the head of the bed. This had a special meaning for us because Daniel, we weren't told about this, developed an aspiration pneumonia with a 6-centimeter abscess. Ann and I, both being physicians, we have resources, so we treated him with 4 weeks of IV ceftriaxone at home. But you don't want this happening to your kid. Take care of the drooling. Botox works. There are more and more ear, nose, and throat and neurologists doing this. Don't let the constipation happen. GI hypocontractility is almost universal. They're really funny about that. They say, oh, it only happens in a certain percentage. It happens in all of them. It's physiology. Give them a bowel regimen. Everyone's different, but if you mix and match laxatives, be it Ducalac or bisacodyl or Senna or Docosate, which is Colase, we use tremendous amounts of Miralax. I'll use milk of magnesia as a bailout. We use the Secretogs when we're stuck. Don't let it happen. Clozapine takes a normal transit time of 24 hours and turns it into a 48 to 72 hours transit time without treatment. You don't want these kids having rocks. You want to buy a Bristol stool chart. You want to show your kids. You want to just not ask them, how's your bowels? You want to be specific. You want to say, what does it look like and how often does it happen? Because especially in the hospital, it's almost all of them, and they all say, I'm okay, because they all have alogia, and they all have disorganized thoughts. So they're not going to give you a great answer in the beginning. You need to know. Neutropenia, oh yes, thank you. My wife, Dr. Mandel, no Metamucil, never, ever use fiber supplements. Fiber supplements will further slow down transit time. You will get a concretion, you will cause an impaction, and you could do serious harm. Neutropenia, we talked a lot about, but I never want you to have to slow down and stop the clozapine. I've had white counts that presented to me at 600. I didn't stop the clozapine. Why? Because I repeated it right away. I made them come back, do it again in the afternoon when it was done in the morning, because there's a circadian rhythm of neutrophils, and I had them exercise. So what happens is white cells live on the margin of blood vessel walls. As you exercise, you recruit those. white cells, and that's about 50%. So you can get quite the bump up with 5 minutes of vigorous exercise. And then I'll add lithium early on, because lithium is a granulocyte stimulating factor. The more higher lithium you go, the more you'll have stimulating factor. I have never had to use granulocyte stimulating factor. Also, recognize Ben, David Taylor, in his work. We always think it's in the Black population, so we're actually calling it BN now. We've taken out the ethnic part of the benign ethnic neutropenia, because 20% of his population has neutropenia. So don't let neutropenia bother you. David Taylor says, and I agree with him, and also Dan Siskind, who just published the article looking at the experience in Australia and New Zealand, where the 2 years there was no severe neutropenia. So Taylor's point is, why are we measuring these white counts? Because, if you look at the agranulocytic kids, it's very characteristic. They rapidly drop and they go down and they stay there. It's not like what we see with COVID, where I've had some of my patients, while hospitalized, have their clozapine stop, where it goes down to around 900 and hovers. So neutropenia, that monitoring system makes no sense, and we are stopping treatment inappropriately. All right, nighttime urination, ask about it. Kids are embarrassed. They don't want to tell you they're bedwetting. I'll tell you, the oral DDAVP starting at 0.1 milligram, and I've gone as high as 0.6 milligrams. It's short acting. It's got a half-life of 8 to 12 hours. How long do these kids sleep? Most of my kids sleep at least 8, but most of them in the very beginning sleep up to 12 hours. Don't sweat that, but don't let them pee on themselves. This stuff works. Myrbetriq is somewhat useful, but you have to be cautious with that, because it's also will slow down and make constipation a little bit worse. Hypotension. Again, if you go slowly, it's not a huge issue, but when you get into the bigger doses, it can happen. Don't be afraid. You have to encourage these kids to drink, because what is clozapine? What other indication does it have? Well, a lot of the people have psychogenic polydipsia. Clozapine has the indication for that. Kids do not drink as much, and they often don't drink enough fluids when they're on clozapine. So encourage salt and water, but if need be, give them a mineral corticoid starting at 0.1 milligrams. Fludrocortisone works pretty good. All it does is cause salt and water retention. Is hypokalemia a problem? I've never seen it, and I use a lot of fludrocortisone. I've gone as high as 0.4 milligrams. Doesn't mean you don't monitor, you look. You're doing blood work anyway. Nausea and vomiting. Well, your GI tract gets slowed down from your mouth all the way to your anus. It's not surprising that they have nausea and vomiting. And as you see, I use a lot of supplemental drugs. I want to work on the constipation. I want to work on the weight gain. Some of those drugs also can cause nausea. Don't be afraid of using ondansetron. It works directly on the chemotrigger receptor zone in your brain. It's extraordinarily well tolerated. I will very early use 4 to 8 milligrams. The other drug I will use, and I didn't put it here, is metoclopramide. Everyone's afraid of metoclopramide because of tardive dyskinesia. But the reality is it has a much lower risk of tardive than all the other antipsychotics that you guys are using, and you don't need to use much. I get away almost universally with 5 milligrams or so twice a day. This slide's interesting and somewhat important, but I want to stress you do not start to use any pharmaceuticals to enhance cognition until you have very good control over positive symptoms. This is a mistake I made early in my career. I got impatient. And what all these drugs work at, donepezil indirectly, because that's more on, cholinergic, and acetylcholine, obviously, in your brain. But there's the play on dopamine. Bupropion, again, nicotinic receptors, but there's that play on dopamine. Even the famotidine at high doses, which stimulates histamine in your brain. What's the secondary outcome? It's dopamine. Mematine, a little bit different. That's more on the glutamate pathway, right? It partially blocks the NMDA receptors, and it helps with transmission. But ultimately, it's, again, dopamine dysregulation. So you have to be careful with these things. They will help, but you need to wait to use all of these things, especially the modafinil and the armodafinil, which are the indirect dopaminergic stimulators. They work. They will improve cognition. They will allow these kids to get up easier in the morning. But wait. And always, as I said, consider fluvoxamine. Wakix, I'm going to take this off the slide. That's a direct histamine 3 agonist in the brain, or antagonist. It increases histamine. We may be using the very lowest dose was okay, but we really drove a lot of psychosis with that as we got past the initial dose. I think that's 4.5 milligrams. There is, I always kind of poo-pooed the OCD component, but it kind of makes sense. We know that it blocks serotonin, and so I do go after some degree of the OCD, but I will tend to use more fluvoxamine in that setting. But I won't do that early. I'm going after the psychosis. And I find, so psychogenic rumination and obsessive compulsive disorder, they kind of, they're tough to tell apart, and they often kind of bridge each other. These intrusive thoughts that you might call OCD, I think are more often than not the psychosis. But having said that, there is a role for fluvoxamine in this. But what you can do early on in enhancing clozapine, and what I absolutely insist upon, once they're well enough that they can participate, I get all these kids to therapists, and they do psychosis-informed CBT. And what's been amazing lately is we have a functional cognitive enhancement treatment program. And I know you guys do it as well. And we have a program that is online right now, and we use it with Laurel House. And they use primarily Brain HQ and Lumosity as their base, and they have social groups around that. And I believe you guys are doing that in most first episode psychosis programs. That has to be emphasized. What's cool is once they're on clozapine, they can participate more at all these things. And that I can't emphasize enough. And obviously, you go after co-occurring addictions. We do use a fair amount of naltrexone, for instance. Now, I think you would have shut me down if I put this slide earlier, but it's a lot of work. It's a lot of work. You got to go after the side effects, and our average numbers of prescriptions are 11. I'm fond of saying, one thing I learned as a nephrologist, I used to take care of lupus patients and transplant patients, and they're a serious disease, and they're complicated, but they can do extremely well. But you have to manage the illness. And it's the same thing with these psychotic disorders. These are really diseases that will absolutely ruin these kids' lives unless you're incredibly aggressive, assertive, engaged, and willing to do what you need to do. And kids will do this. And as I said, we have over 250 kids doing this, and this is our average number of prescriptions. You'll notice there are a few things I don't use. I don't use multiple antipsychotics. Almost everyone, half the kids are on multiple antipsychotics when they come in there. Everyone likes to keep people on paliperidone, 234 milligrams. That's supposed to be the loading dose, and then you're supposed to go to 156. I can't tell you how many kids I have that have come to me on 234. I get them off, and I've been able to universally get them off. I don't get everyone off. I have, I think, three kids now, because I just stopped someone else's paliperidone last week, that are still on another antipsychotic. One person who's one of my stars is on 1 milligram of Risperdal because she happens to take 400 milligrams of armodafinil, which is way beyond what she should take, but because she works 50 hours a week and is a psychiatric social worker. I've been after her to not take so much armodafinil, but it's been a negotiated settlement. She's been doing this for 30 years. She's very functional. She has a great life, makes more money than I do. So who am I to say? But nevertheless, there's a cost. She needs a little bit more than what I can provide with clozapine, and she won't let me take up higher levels. But what I don't use, I try to avoid Depakote because it tends to worsen the sedation and the weight gain. And it also puts them, especially when you're starting people on clozapine, it puts them at higher risk, even though it's very low, but it does put them at higher risk of myocarditis and agranulocytosis. There's no reason to use benztropine with clozapine. Movement disorders are not a thing on the vast majority of these people. So I don't. And I certainly don't use it for saliva because I use glycopyrrolate when I do too. You guys love, and I've seen this more often than not, I shouldn't say you guys, that's not fair, but I've seen more often than not hydroxyzine. It's an anticholinergic antihistamine. Sure, it sedates, but why are you going to put that burden on these people? It makes little sense. And what I never, ever, ever use is direct dopamine stimulants. That is just an egregious error. Dopamine dysregulation, are you joking? We know that cannabis increases the risk for psychotic illnesses. We know that stimulants also dramatically increase that risk as much as 5-fold. What are we doing adding a direct stimulant? It makes no sense. I will use benzos. There's, again, often there's an imbalance between excitation and inhibition, where you have the glutamate is your biggest excitatory neurotransmitter, and the GABA system is how you inhibit. And you may need to use benzos, especially early on. I can't get away from that. They are a bailout. I tend to use beta blockers with low dose of clozapine as PRNs as these kids get better, and I try to get them off of benzos. But it's not a never. What do I always do? What do I emphasize? I'm a marathoner. I hope to see some of you up there. Maybe I could convince Kesh that we could do something formally when I go up and run Boston. I've run the last 25 Boston marathons. For me, it was an escape probably from mental illness. I have a grandfather with schizophrenia, an uncle with schizophrenia, and an aunt with bipolar illness. When I was in high school, I was a straight A student. My junior year, I went into a deep, dark depression that no one really recognized because I still functioned, but it was not great. And I think in full retrospect, that was probably my depressive phase of a bipolar illness, and I've kind of lived a hypomanic existence. And how have I done that? What's been my drug? It's been exercise. I've been running ever since. I started running. I've never been depressed since then, and I've run 110 marathons. So I emphasize and I push. And this is where it started. We have our kids come to my house and they run with me. And the house is magic because it normalizes, and they develop friendships. They develop a community. How much of this is isolation? What's the worst thing you can do for your brain? Is isolation. Your brain needs stimulation. When COVID came, we went to Zoom, and then we went to outdoor things. So right now we're in the winter. I don't want to be a rapid spreader, so we're Zooming, and I still have a few of my kids come over and run. What has exercise been shown? Has it been studied? I keep seeing this stupid another study. Every study always shows the same things. Kids get better in every way. And you know what? I couldn't get Daniel to exercise till he was on clozapine. He wasn't well enough. But these kids are engageable. It's magic. The two kids at the end, they just completed Philadelphia in 3:19. The one in the middle next to me, he's running his 4th Boston Marathon this year. The other one is the 3rd. And the other guy on the side, he's just the director of mental health for Westchester County. But we let him run with us. I can't keep up with these kids. It's very embarrassing for me. I've been better than them for a long time, but they're going to probably go into 3:10 at Disney. Anything is possible with clozapine. That's what I want you to know. How many of your kids are running marathons? Diet. Basically a Mediterranean diet. Don't discount it. And they will do it. My kids lose weight. They will participate. They show me diets. Whoops. Go back. And again, I can emphasize this again, time and time again. When you start, go slow. This is just to show you the complexity, because I always like to show the tables as initiation table. This is tables, and both of these tables, I put it there because it's in the ease paper. Get the ease paper. Kesh will provide it for you. It's useful to have. You put it in your pocket. It's not everything, but it's a start. Again, slow. You'll figure out your lowest dose. everything is easier and the risks are much reduced. And expect a long cross taper. It usually, as I said, takes me 6 months to a year to get people off of their other antipsychotic. It's not unusual. Again, as I said, maybe 10 times as fast, but 6 times as fast. This is the manufacturer. This is our approach. 50's a rush for me in a week. That's really quick. And that's one I'm really pushed. And that's unusual. It's almost always 12.5 or 25. These are doses. They're deceptively low because fully now 70% of my kids are on fluvoxamine. So, but if you look at the spectrum of illness, you're going to use less with a less pervasive illness. That's the point of this slide. And our averages aren't that high, but they're all over the map. And that's why you start slowly. I have a kid on 25 milligrams. The aforementioned Eric Smith, who required an AOT before he got well, is presently on 75 milligrams and does blood twice a year. And that's it. And he's on nothing else. So the doses are all over the map. You gotta just go up and you titrate. Now, the levels are something else. A full quarter of my individuals are over 900. My mean level is almost what I get reported from Quest, or, they call me up all the time saying you're in the toxic range, because the 700 is the range that people say, oh, I can't go higher. That's a bunch of crap. Kids continue to get better, and a lot of these kids need higher levels. But when you do it, as you go up with clozapine, what happens? What's universal? The GI side effects and the seizure threshold. You need these kids on seizure prophylaxis. Back to the CYP system, 1A2, which again, 70–90% of metabolism is through that system. Be aware of cigarettes, please. Hydrocarbons and coal tar will speed metabolism. If a kid does get admitted, and they still do get admitted, especially early on before they really get well, and they're smoking and you stop the cigarettes, if you don't adjust, I've seen seizures. You can see a doubling and tripling the level. That's extreme. It's usually only about 40 or 50%, but it's variable. Caffeine also increases level a bit. So I always tell people, keep it moderate, certainly no more than 4, preferably 2, because how does dopamine work? Dopamine displaces adenosine at the presynaptic cleft. And what happens, and when adenosine is displaced, what does that trigger? It triggers dopamine into your synaptic cleft. So it's all about dopamine. You drink 6–8 cups of coffee, you're going to get dopamine dysregulation. So be careful. And again, always be aware. You have to be a doctor. You have to be aware of drug interactions. Cipro will triple your level. Paxlovid for COVID. The ritonavir will triple your levels. Inflammation, as I already aforementioned, will triple your levels in a severe case. But you can use this same pathway to make clozapine, I think, a better drug. And that's what we have. Some of these kids where we needed really high levels and they just weren't getting well, or they wouldn't stop smoking and I couldn't get levels, I started to use fluvoxamine. And what that allows me to do is take the clozapine and change the ratio at 12 hours from clozapine to norclozapine of 1.3, because it's not only the clozapine that causes the side effects, it's the norclozapine as well. And the way I look at it is, and what I've used as a rough estimate is, I'll go up to a total of 2,000 nanograms between the clozapine and norclozapine in terms of side effects. After that, I've run into trouble with really terrible side effects. And then I'll turn, if this is not enough, when everything else fails, always what's the next question, is fluvo first and then ECT second. But what I've seen with fluvoxamine is there's something about the drug itself, and I'll take it up very carefully because it is an SSRI, and you don't want to, especially in my bipolar population, trigger mania, you go very slowly. I start at 6.25. And I very cautiously go up and I check levels. Even at 6.25, I can see a 20% increment in clozapine levels. But I will change the clozapine dose after I find what I want. And so that I'll take the ratio and I'll make it 2.5 and often more than that to 1. And I've seen improvements in sleep time, sedation, somewhat negative and positive symptoms. But what I always see is an improvement with the salivation, because norclozapine, being muscarinic for the salivary glands, causes most of the hypersalivation at night, the siluria. The risk, again, seizures. So you got to go slowly. So the general model, us, an NP, I think they're the way for the future. That's who I'm training, but I would love to have a psychiatrist. MDs, there's just not enough of us. There's just not enough of us. And there's such a need. I think you need to have someone do you guys are more adept at the therapy. I don't try to do therapy. I have a psychiatric social worker in my office. I have my peer specialists, thank you, Eric Smith, and Michaela as well, and normalize. You got to set up a community. It should be part of every first episode psychosis program. Have these kids do a picnic. Have them get together. I can't emphasize it enough. You got to do exercise. You got to do the family. The family's got to be involved. It shouldn't just be the kids. The family's got to know each other. They can be your support structure. I want this to be a movement. People have to understand we've been doing this wrong for so many years. There's a better way. Substance abuse, dogs. As I mentioned, Minnie, you stare into a dog's eyes. This is something I've been using more and more, is oxytocin. Rocky Murata at Silver Hill Hospital is a big proponent of that. I don't have it on any of my slides. I have about 50 or 60 kids on sublingual preparation. You can get it from a place called Belmar Pharmacy in Golden, Colorado. If you want to know, I'll give you more information about that. It seems to do something. I'm not exactly sure what, but it seems to help a little bit with social cognition. The good news is there's no downside to it. Other things that I haven't mentioned is N-acetylcysteine. There may be some evidence for that, especially at the higher doses and it may have a role with OCD. There's a lot of tricks. And these are my other slides that I didn't try to present today just because it's too much. So the other thing, the blood draw, because we still are stuck with it. We're still stuck with REMS where you have to do the first week every 26 weeks. I actually, sue me, but at 18 weeks, because you can move it, if you go on to the REMS, you are in charge of when you move the monitoring. I move at 18 weeks. I actually like the first 18 weeks for them to come in and see them weekly because it's therapeutic relationship so important. So I like that first 18 weeks in most of my kids when I start. I want them with me, but I don't really care that much about the white counting. I'll do it, but the risk is well less in our population. The real numbers, 2 in 10,000 individuals. What are we doing? It's silly, but nevertheless, you can do a finger stick for those just to maintain them. This is an Atlas device. GGP, which is Golden Gate Pharmacy, ggprx.com/Clozaril if you want to get your kids on this. A lot of people with Medicaid, for instance, in New York State, if you have a Medicaid plan, in my state, you can get people automatically on Clozaril. And that's one other point I wanted to make while I'm talking about this. When you're on clozapine, not all clozapines are created equal, guys. And again, I work for no company, but you need to stick with one formulation, whatever it is. If you can get Clozaril, there's going to be less variance. But the reality is there's often is a narrow therapeutic window on these kids. And if you switch from one generic to the other, you can have as much as a 20+ variation in your levels. So if you get a drug, find out what generic is available to you if it's only a generic, but stick with it, and that will help minimize your variation. But if you go from one to another, you're going to add something that you don't want to do to your system. But this is very helpful, and it is accepted. This is our Zoom. This is just some of the people that we do every week. Whoops, what am I doing? There we go. This is what people say. It is an awakening. The lights go back on their eyes. This is a picture is worth, 1,000 words. This is a kid before clozapine, before getting psychotic, great artist. This is on olanzapine. The images are distorted. You know, everyone has seen the great artist who does the cats, where it's just, you see the disintegration of the cats. This is similar, but this is our version. And this is on clozapine early on, remarkably better. So again, what are the realities? There's a lot of people out there suffering, guys. It's lifelong. People need to be on clozapine. It's all about neurocircuitry. It takes a very long time, and we can do a lot better. That's the book. The 5th edition is coming out next year. It's been extensively rewritten, my part especially. So it'll have all my slides and everything else, and the ease protocol as well. Clozapine Handbook by Meyer and Stahl. There's a lot of synergisms. I think you need them both. It's just the reference. I always like to do that. And that's my contact information, and love to take some questions. Thank you for giving me all that time.
Oh, thank you very much, Rob. I'm sure there are lots of questions, and there are some in the chat. So let's see if there is anyone. Please unmute yourself and ask the questions. If not, I can bring them up from the chat.
And I really do like people to get a hold of us. And, you know, we invite you to our Zoom calls. Other psychiatrists have gotten on our Zoom calls, and the nurse practitioners. I don't know everything, that's for damn sure. But I've been reading this stuff for 15 years, and I've read a lot. And I don't want to be immodest, but again, with side effects especially, I think we've worked through a lot of this. So there's so many tricks. There's so much nuance. So if I will gladly get you on our Zoom calls and our listserv. Kesh is subjected to my emails at 3 times a week, you know, whenever I find an article. So please, we're all in this together. This is really, we've got to change the way things are done. I'm sorry, I'll shut up.
Rob, that's great. That's outstanding. Really excited about it. In the very, very long run, do you reduce with clozapine?
In the very, very long run, typically, yes, because they get better. You know, again, I always tell this is such a long process. And when they're at their sickest and there's the most neurodevelopment going on, often, you know, you're fighting this battle with a lot of pruning going on at the same time. These 18, 19, 20-year-olds. It's like one of my favorite lines from Friedman's lecture when he's talking about, you know, the how we can maybe get rid of schizophrenia if we give the supplements with the lecithin, you know, but what he says is, I tell all my kids and their families, buckle up your seatbelts because the next 10 years are going to be rough. And there are going to be bumps along the road, but you get into your late 20s, your 30s, yes, that's really typical. But Ken, really important, I go down I go down so slowly because the big mistake is overshooting that mark because they need clozapine for life. I don't know how much, but I go down, if I go down, I go down like 12.5 milligrams every 2 months. Really incredibly slowly. You don't get into trouble doing that. Go ahead, Max.
Yeah, I just wanted to say that I came across your book a couple of years ago, and I'm an acute inpatient psychiatrist, and it was really hard to get through without getting like emotional and tearful during it. And it has been really like probably my biggest influence over the last 3-4 years. So I just want to say thank you.
Oh, thank
And
you.
yeah, I wish that information got out there because it feels like I wish I would have known things 3 years ago that you put together so nicely now without having to go kind of find them out.
Yeah, no, it was, we were amazed that we were the first clozapine book that came out. Remember, the drug's been around since 58. You know, Ann and I both pinch ourselves that we're at the forefront of the movement. I mean, and again, that we get such acceptance from you guys. I mean, it really warms our heart. Because who am I? I'm just this freaking little nephrologist sitting there in Westchester reading articles.
Can I ask you a question?
Sure.
You mentioned before that there's that the clozapine was put in a box by, you know, among others with the Kane criteria, with the same people kind of deciding where research dollars go, and still very much in charge of the system, you know, Carell and all those guys, Leslie
Yes.
Citron. what is your realistic chance that things change?
I think they will change. That's why I have 5,000 people on my Facebook page. It's going to be the moms. It's going to be my angry moms going up and showing the psychiatrist. So what we always tell kids is, go back and show your original treating psychiatrist that wasn't going to give them clozapine. And go back and just make an appointment and show them what they look like. So we have a party at my house every August. You guys are all invited because we had over 250 people in my backyard. It's a nice little spread. And what that party is a celebration over 2 days of people from all 40 states. But it's also the psychiatric community because you can't tell who's on clozapine. You can't tell who's got the illness. It's the level of recovery is just remarkable. I have 2 people, they're a new startup. They just got funded with a few $1 million called Doramind, and they want to take my model and generalize it to the community. So I had 2 guys shadowing me. And, they told me they were coming the day before, so there's nothing special on who they were going to see. The first person they saw works 46 hours a week and is a firefighter. The second person they saw is my psychiatric social worker was in. Another kid I saw is full-time in school. Another kid was one of my marathon runners. So it was one after another after another. I have a kid who was stuck trying to get his math PhD, and he teaches at City College right now. He's an assistant professor. It's just you got to see it to believe it. I didn't know what I was going to get when I got Daniel started. No one told me that I could see as much recovery. I mean, my son is a stand-up comic. Think about what you need to do cognitively to be a stand-up comic, right? You have to memorize 20 minutes or more material. You have to deal with an audience that is often not the friendliest in the world. You have to have a good sense of humor and how you can engage that audience. It's, for anyone, a huge cognitive stretch. I mean, and this is a kid who has schizophrenia, had a neurodevelopmental disorder, and yet he's on stage and he thrives doing it. And, he's not the exception. That's the point. So, Max, I think, yes. I think I always tell people it's a 30-year project. I'm 15 years in. But, there's exciting stuff coming down. My dream is to have a delivery system that's the best, which is a long-acting delivery system. And we're going to start. I was talking to Kesh before we got on, and we're starting the process with David Taylor. He's got a Celestic implant where he's got 250 milligrams of clozapine and 50 of fluvoxamine, and we're going into pigs right now. We are way, way away, but it delivers drug, and and it's removable. So it takes that other factor out, because the problem with clozapine, with the metabolism, if they get ill, you want to have the ability to take it out and convert over to an oral regimen. So, and it's weekly. We can get enough weekly drug, because if you think about it, and, the formulation, hopefully we can get it better, we can get more drug in. If you take 250 milligrams, in most people, that is essentially tripling. So you're up to 750 milligrams equivalents. And the bioavailability between the subcutaneous IM formulation and oral is about 50%. So now you're up to 1,500 milligrams delivered in a week. You're getting there. You're getting there. You're making, significant progress. I mean, we're a million years away, but at least the process has started. Any other questions? Sorry,
So Rob, in the last minute that we have, can I ask you a kind of a difficult question, but it may not be difficult for you, given how much you have seen in your experience. I encountered a patient who did not respond to clozapine even in some supratherapeutic doses, and did not respond to ECT, and did not respond to an additional second antipsychotic. What do you do with such people?
right now there's a study protocol because I have a kid that I did absolutely all three of those things. And they just got their fancy functional MRI. We're going to map her brain and we're going to start the SAINT protocol on her. That's the next step. Then there's Helen Mayberg, who wants to do deep brain stimulation. That's it right now. And before I go to deep brain stimulation, I want to play out what they're doing up at Harvard. And so I have my first person coming up from Florida. That's going to be in January. So I'll let you know. That's the next step. And yes, that is exactly the steps that I've done. So if I fail my super therapeutic, and this is a girl I took up above 1,500 nanograms per mil. I mean, she's much better. She's extremely pleasant, but she still has ongoing delusions, and really is not even close to getting back to school. And then I did a full course of ECT. And then after talking to my friends in Australia, they said high dose lorazepam, because I thought that was a rather benign D2 addition. I took her up to 160 milligrams of lorazepam. Nothing. So now she's going up to Harvard. That's my next step. So yes, it was relatively easy, but there's not a lot yet out there. There really isn't. And can you get everyone better? No. But do I get over 90% significantly better and 75% or so in meaningful recovery? Yes. And that's a hell of a lot better than anyone else. I want to do better though. I want 100. I don't know if I'll ever get there. Yes, Holly.
Hi, thank you so much. This is so inspiring. I know we're a minute over. I'm so sorry. I'm a social worker, but thank you so much. I know you said that you're not taking new patients, but you may do consults. If we have a consult that we think would be a good fit, is there a best way to do that?
Yep, get a hold of me.
Okay, just any of this contact information, reach out?
That's how anyone gets a hold of me. This is all my patients have this. That's why I had to shut off my phone. This is why I'm also trained my NP, because my wife and I have not been able to go on vacation since when? It's been several years because I can't shut off my phone.
Please don't take one.
Oh, no. I'm not retiring anytime soon. My dad worked to 96 as a clinical psychologist. I'm 66. Cash, don't you dare retire on me as well. We're in this. We have at least another.
We are in it together.
We're in this together. Yeah, no. And again,
thank you so much.
I so appreciate the opportunity to talk to all you guys. And, I hope, Cash, what I would love is the April opportunity, because I gave a 3-hour talk for Montefiore, and that's, a lot of it's repetition, but every time I do the talk, I talk from my heart, and it changes every single time. The slides are the same, but I add the full slide set, and I'd really like to dwell on how to really go down the side effects, because they're treatable, and it's so much fun. It really is so much fun. And as I said, I've never done anything more gratifying in my life except marry my wife and have my kids. I'll still rank that a little higher, though my wife thinks maybe I don't believe that, but I do. But outside of that, professionally, I've done nothing better than this.
So thank you so much, Rob, for all that you do.
I had fun. I hope you guys did too, and hope some of it.
And for everyone,
one other thing, Kesh has all my slides, has the full slide set. So if you need that, you can get it from Kesh. It was one of the listservs. That was the talk I gave. So it's all there if you need it.
And also your talk is recorded. So
yeah, and the talk is recorded. This talk is recorded, and the 3-hour talk is recorded on that as well. So if you want that as well.
All right. Have a good rest.
Yep. Thank you guys. Have a great
thank you
weekend.
so much.
Thanks. Take care, guys.